Good day. Today we are talking about perinatal depression. My name is Dr. Laban and I'm a psychiatrist at the Reproductive Mental Health Program in Surrey. I have with me today Tammy Stott, who's our clinician at the program. Tammy's been with us in the program for a very long time and is an experienced clinician and counselor. She's a psychiatric nurse and has been working with patients who are pregnant and postpartum, especially with counselling, assessments, and therapy. So Tammy, what would you say are the management strategies recommended for women experiencing postpartum depression?
One of the biggest things that we use is a preventative strategy. We use the NEST model. So it's an acronym that stands for nutrition, exercise, sleep, time for self, and support. It's used as preventative, but also in all cases with all clients. I think women very much are socialized to give everything and to look after their partner and their children at the expense of themselves. But at the end of the day, they need to look after themselves before they can look after anybody else. And I always say to them, you can't pour from an empty cup. There's going to be nothing left, right, to give. So I encourage them to ensure that they look after themselves in all these different areas. A couple of the biggest ones are sleep is so important and it's so vital. And so oftentimes I'm doing a lot of brainstorming with my clients around how can we get this woman enough sleep or more sleep, right? Because, she's got a newborn, she's up every 2 hours for feeds. So sometimes it's being a little bit creative and also pulling in the partner and brainstorming together and figuring out ways that we can kind of, make this work. Maybe she starts doing some pumping and the partner takes a feed, even if they're back at work, maybe they do a late night feed or an early morning feed before work, and it just gives them a little bit more of a stretch of sleep. That can make a big difference. The other piece is support, and again, thinking sometimes outside the box on, ways that we can get them the support that they need, whether that's practical support or emotional support.
So if a family doctor wants to talk to his patient and their partner about self-care, how would he go about doing it if the partner's working and if there's no family support?
Well, I think one of the biggest things is, again, we have to sometimes look outside the box, right? What does that look like? And, is there things that maybe they can do? Can they bring in any help if they can, like such as a postpartum doula or something like that? Do they have benefits that would cover that? Some benefits will cover a postpartum nurse. Maybe they could temporarily bring in someone to help with cleaning the house or something like that. It depends if they can afford it, obviously. These are sort of those extras. But then also simplifying things, right? Like instead of grocery shopping, order online, have it delivered, do things like that make things a little bit easier for you. But I think a lot of it is just, working together with the couple and kind of figuring out the best ways that we can get support. And again, sometimes looking outside the box that you don't realize what supports you have until you really look into it. Maybe there's supports at their church or in their community or through a mom's group or something like that.
So if someone was following the NEST model, for example, during pregnancy and learning about how to take care of themselves, does it help prevent a mom from having postpartum depression?
It's definitely a big technique that can help with prevention. Lack of sleep deprivation can be a huge trigger for perinatal depression. We see that a lot. Lack of support, that's another big one. Not eating properly, right? All of those things are big triggers for, or risk factors for perinatal depression.
Okay. So which forms of psychotherapy are evidence-based for treatment of postpartum depression?
So based on the best practice guidelines that were completed through the BC Women's Hospital in 2014, they have identified cognitive behavioral therapy as number one, and then interpersonal therapy, followed by psychodynamic therapy and couples or family therapy and group therapy. We also will do mindfulness and relaxation exercises as well.
So if you're a family doctor, I'm sure that interpersonal therapy would be interesting for you to do with a couple. So how do you go about doing interpersonal therapy?
One of the biggest things that interpersonal therapy touches on is the changes in identity and roles, as well as changes in the relationship. Even with women who have planned pregnancies that they are excited about, it is still a big adjustment. They may be career women and now they're off work for 12 or 18 months, home alone with an infant and no adult interaction, right? It can be quite an adjustment and quite difficult. And so normalizing that and helping them to work through that sort of transition into new roles, as well as the strain that it can put on relationships as well, and recognizing that the changes that are going to happen in their relationship.
All right. So most family doctors, I think, do some supportive work with their patients. They know them for a long time because they've been seeing them through the pregnancy. How would cognitive behavioral therapy be different from the normal supportive therapy they do with their patients?
With cognitive behavioral therapy, it's about the emotions, the behaviors, the thoughts, and the behaviors that are all interconnected. So with CBT, we always start with behavior first because it's the easiest place to start. And so setting very small, SMART goals, right, that are measurable, achievable, realistic for mom, though that's the best place to start. And we usually set them around the NEST model, so it's around self-care, right? So maybe she sets a small goal to take 15 minutes to herself, time for self, to read a book or to take a bath or something like that, right? Again, we may need to pull in her partner or support people to ensure that they're able to support her with that. But setting those small goals is first place to start. From there, then we work on identifying the thought patterns, and there's often very negative thought distortions that occur that fuel that depression and anxiety. So recognizing those thoughts and helping her to challenge those thoughts.
Are there any unique features in someone who's pregnant or postpartum with regard to their thoughts that would help a family doctor identify a woman who has postpartum anxiety or depression?
Definitely. One of the biggest things that we see are women experiencing intrusive thoughts. About 40% of women that are pregnant or postpartum will experience intrusive thoughts. And quite often they're afraid to talk about them. They think that people are going to judge them or they might have their baby taken away, because often these thoughts revolve around baby and something bad happening to the baby or them doing something bad to baby. For instance, they're in the kitchen and they see a knife on the counter and they have an image of them hurting the baby with the knife. They have no intent of doing this, and in fact it's extremely distressing and causes extreme guilt. That's how we know it's an intrusive thought and not something different such as postpartum psychosis or something like that, because we know that they recognize it as a thought and that this is something that is causing them distress and guilt. That's the difference, and we need to normalize it. We need to help them to understand that this happens so frequently and she's not alone. And this is a safe place to talk about that. That's the biggest thing.
And what groups do we offer in our program that a family doctor can refer their patients to?
So when you refer your clients to or your patients to reproductive mental health, everyone is seen initially by psychiatry and have an assessment done. And then from there, they're referred to group. And almost everybody is appropriate for group. Right now, currently, we don't have anyone that has experienced a perinatal loss in group, just because it wouldn't be appropriate until we have a group specific for that. But everybody else would be appropriate for a reproductive mental health skills group. It runs once a week for an hour. It's done virtually, which has reduced a lot of barriers for a lot of our clients. So many are able to attend regularly when they wouldn't have been able to otherwise. And there's 10 modules that touch on self-care, the NEST model, basic CBT, and mindfulness and relaxation exercises. And the modules just repeat, and it continues on every week throughout the year. They also are offering it at the RCH, Reproductive Mental Health, and Burnaby. And then we also provide a closed CBT group that's a 10-week group for women that are experiencing perinatal depression. So it's 10 sessions, 2 hours a week, and also has 2 evening sessions. One is for partners, just providing psychoeducation and support for them. And then another session that is for joint for the women and their partners together. And it works on communication, conflict resolution, those sort of things.
So do dads get postpartum depression?
They do. And again, that comes back to the changes in identity and role and expectations on them. That's quite often one of the risk factors, although there's many others. And in fact, the stats are quite similar to that of women, which is quite surprising. There isn't as much support out there as there is for women, but we're working on it. So as part of our CBT group, we do have the support classes for the partners. We always welcome partners in our individual sessions. And if we identify them as, that they're struggling, we will refer them on for different resources. And there are some online resources available to them through Postpartum Support International and Postpartum Support Society here in BC that have online virtual groups.
Okay. So, are there any community resources for moms who can't attend our group program either because they don't have the capacity to while they are postpartum or they've gone back to work or part-time working?
Postpartum Support International has a lot more resources with varying times that they'd be able to attend, and especially if they're not able to attend ours on a Wednesday afternoon, as well as the Pregnancy Hub has a lot of resources that are offered virtually as well.
Okay. For family doctors, when they are counseling a patient through the pregnancy and postpartum, are they able to refer the patient to our program if they're concerned?
Definitely. We like to work as preventative as we can, and so even if they are at risk, we will see them and we will monitor them closely throughout the pregnancy and into the postpartum, because someone may not be displaying symptoms yet, but they're, quite high risk because of situational stressors or a history of mental illness or, many different factors. And so they can attend our group, and if needed, they can see psychiatry or individual counselor.
So some of our family doctors may have heard about the Seamless Perinatal program.
Mm-hmm.
So maybe some information that would help them understand better how to refer someone who would qualify for the program.
The Seamless Perinatal program gives access to a social worker who's able to help with a lot of additional resources that we don't have access to, such as housing or financial stressors, things like that. And they have a referral form they can be faxed over. They're located in Jim Pattison, and we often work in collaboration with them as well.
And final question is, if we have a family doctor who has a mom who does not speak English, how can they get them the help that they need?
We provide services here using interpreters, whether that's a phone interpreter or an in-person interpreter, and we still provide psychiatry assessment that way, as well as counseling sessions. We've done that with interpreters as well. We can also refer to other community resources such as diversity or something that, if they are more comfortable that way as well.
Thank you. Thank you, Tammy. That was very informative.
Thank you.